Welcome to today's lecture, Social Medicine and Community Health in E-Pathshala. We will be covering healthcare delivery system and in special the topic for today, the primary healthcare in India. Now, thanks to the development team, that is thanks to the guidance of Professor C.P. Mishra and his colleagues from Aligarh Muslim University, and we finally come to the learning objectives. Like I have said, learning objectives are a must to define objectives because this is what we intend learning after the lecture is over. So what is it that we want to know about primary healthcare? What is primary healthcare? What are the goals and principles of primary healthcare? Approaches to primary healthcare. In other words, with these goals and principles of primary healthcare, how do we want to approach? How to set up the primary health center? Now, what is primary health? Primary healthcare actually refers to essential healthcare that is based on scientifically sound and socially acceptable methods and in other words, it is the basic, minimal, complete healthcare which should be acceptable, which should be approachable, which should be available to every single person in the community at a very simple cost and with ease and comfort. This is actually the definition. But when you define it, it means essential healthcare that is based on scientifically sound and social acceptable methods and technology, which makes the universal healthcare universally acceptable to individuals and health families in a community through their full participation at a cost that the community and country can afford it. So to maintain at every stage of their development in the spirit of self-reliance and self-determination. In other words, healthcare which is affordable, which is acceptable, which is approachable, and which is available to every single person at a cost in which they can take it. This is a picture of a primary health center, and from the dress we can see that it is probably from the hills, from the northeast, and we have primary health centers all over giving primary health care, which is the basic initiative of healthcare. This ideal model of healthcare was adopted in the declaration of the International Conference on Primary Healthcare held in Alma-Ata, Kazakhstan in 1978. And this was known as the Alma-Ata Declaration, and it became a core concept of the World Health Organization goal for health for all. So this was actually a bugle call in the health world for saying that health should be available for each and every single person on this earth at a cost at which he can afford it. It should be easily available. So the Alma-Ata Conference mobilized a primary healthcare movement of professionals, institutions, governments, and civil society organizations, researchers, grassroots organizations that undertook to tackle the politically, socially, and economically unacceptable health inequalities in all countries. All countries differ from all parts of the world, but that is what we had to cover, that the basic health care. So what is basic health care? We will be talking next. There were actually many factors that inspired primary health care. This a prominent example is the barefoot doctors of China. In China, it was seen that now what are the five, we'll talk about that later. Now, what are the five key elements to achieve the goal of primary health care? This is reducing exclusion and social disparities in health, that is universal coverage reforms, organizing health services around the people's needs and expectations, that is a service delivery reforms, integrating health into all sectors of public policy reforms, pursuing collaborative models of policy dialogue, that is the leadership reform, and increasing the stakeholder participation. It means that we have to work around the factors that health should be available for all. So the basic principle of Alma Ata which came out was equitable distribution of healthcare, that is primary care and other services to meet the main health problems in a community must be provided equally to all individuals. Community health participation was considered sustainable due to its grassroots nature. If you reach the community at the grassroots level, people were bound to come forward, accept, seeing one another, accept the services which were being given to them. Health workforce development. Comprehensive health care relies on adequate number and distribution of trained physicians, nurses, allied health professionals, community health workers, and other working as a health team and supported at the local and referral levels. So we must have a proper health force team also who would work at the grassroots level. And this should be accompanied with the use of appropriate technology. That means medical technology. You can't have high-fangled technology and very fancy instruments at the peripheral level. It is not possible. Use or usage of simplest technologies and simple means which could be easily carried to the field, that is what was required. So medical technology should be provided that is accessible, affordable, feasible, and culturally acceptable to the community. Examples of appropriate technology include refrigerators for vaccine cold storage. Multi-sectional approach. Now, we are talking of refrigerators, but this would not be at the village level. But in order to carry vaccines, people had started taking cold boxes wherein the ice packs were kept, and the ice packs would maintain throughout if not used, if used properly and keeping the boxes closed while the immunization was in progress, then this would stay for the entire day, right from the time the A&M left the center to go to the field, vaccinate and come back. And this would be a very good indicator that if the ice pack started melting, we know that those vaccines cannot be used. Multi-sectional approach. Other sectors are equally important in promoting the health and self-reliance of communities. These sectors include agriculture, education, communication, housing, public works, rural development, industry, and community organizations. Then came the section of what is selective primary health. After the year 1978, Alma Ata Conference, the Rockefeller Foundation held a conference in 1978 at the Bellagio Conference Center in Italy. The idea of selective primary healthcare was introduced. This meant it was actually based on a paper by Julia Walsh and Kenneth S. Warren entitled Selective Primary Healthcare, an Interim Strategy for Disease Control in Developing Countries. And it was based on the fact that it would have economical, feasible approach to the primary health center, to the primary health care. One of the foremost examples of special selective primary health care is the GOBI approach. What is the GOBI approach? GOBI. It meant growth monitoring, oral rehydration, breastfeeding, and immunization, focusing on combating the main diseases in the developing nations, and this would also improve the status of mothers and children, both of under 5 and of the pregnant mothers. Now, what is the GOBI FFF? GOBI FFF includes growth monitoring, the monitoring of how much infants grow within a period with the goal to understand needs for a better early nutrition. In other words, registering of all under 5s, examining them, weight taking, and marking the charts therein to see the growth charts, and then giving them the proper education, plus covering them with their full immunization needs as per their ages. Oral rehydration therapy was to combat dehydration associated with diarrhea. Not only with diarrhea, but diarrhea could occur in our country at any point of time because of the fact that feeding is not very regular. A mother's breast milk energy might be low, or she might be not giving water to a 2-year-old child or an under 5, so therefore resulting in oral dehydration. Breastfeeding. Breastfeeding is a factor which has to be introduced right from day one. In fact, previously we used to say that the mothers could wait for about 24 to 48 hours, but today the most important thing is that babies have to be put to the breast even as soon as they are born, even before the cleaning is done. In fact, that is what is being used in hospitals. But okay, once the mother is cleaned up and she has delivered and she is comfortable, because that will permit the milk flow, baby is put to the breast within half an hour to 6 hours. Breastfeeding starts. And the earlier the breastfeeding is instituted, the better it is. Immunization. Immunization during the antenatal period by the 3 tetanus toxoids for the antenatal mother, and after for the 0 to 1 year age group, and for the 2 to under 5 year age group. All immunizations which would include all the vaccinable diseases, that is diphtheria, pertussis, tetanus, then the polio and BCG when it was being given. Then family planning. It's not only the fact that family planning is a subject which has to be discussed when you are sitting in the family and you're sitting at home. No, the moment the patient comes, every single contact with the patient, whenever she comes to the worker or to the health center or to the hospital, family planning is a subject which must be broached immediately. Because it's not only that tube ligation has to be done after the required number of children are born, but interspacing. Interspacing with proper family planning measures would look after the health of the mother and the health of the baby. If she was under family planning control, she would be able to feed her baby for a longer time without getting worried that once the feeding stopped, she would become pregnant. Female education. Female education with regards to family planning, immunization, breastfeeding, giving oral rehydration therapy, or the importance or telling her the importance of growth monitoring is absolutely important. Food supplementation, for example, giving an antenatal woman iron and folic acid fortification or supplementation to prevent deficiencies in the pregnant women. There is the picture of a baby at breast at the moment the baby is born. Now, the PHC has got its own problem. PHC means the primary health care and the population aging. Given global demographic trends with the numbers of people aged 60 and over expected to double by 2025, primary healthcare approaches have taken into account the needs for countries to address the consequences of population aging. That means we have to conduct clinics for the senior citizens and see to it, because their needs would be totally different from that of the normal population. There would be separate diseases, there would be separate care, they would have their own problems, whether it be mental or physical. Now, primary health care and mental problems. Detection, diagnosis and treatment of common mental health conditions at local clinics and organizing the referral of more complicated mental health problems to more appropriate levels of mental health care is absolutely essential. And therefore, this has to be seen to. Now, how we started with the concept of primary health care with the concept of barefoot doctors of China. And they were an important inspiration for the primary health care, because it is choosing barefoot doctors means not going barefoot, but they were doctors who were not doctors, they were actually the village workers, village health workers who lived in the rural areas, received basic healthcare training, were picked up for this intensive healthcare training, and they were sent out into the field to give medical care to the suffering. They stressed rural rather than urban healthcare and preventive rather than curative. So these barefoot doctors initially would walk long distances from village to village looking after the ill and the sick. They had close community ties and were relatively low cost because they carried only a small bag with the necessary items, no expensive, high fangled technological things, very simple. And perhaps the most importantly, they encouraged self reliance. In fact, they spoke the language of the people, so they were more accepted. Now, here is a beautiful picture of the barefoot doctors who have actually trained in these and are ready to go out into the community to serve. But every item has to be taken with a pinch of salt. And that this idealism, it was a very good idea. And it was an unrealistic timetable because we couldn't incorporate the barefoot doctors into our primary healthcare program. More specific approaches to prevent and control diseases based on the evidence of prevalence, morbidity, mortality, feasibility of control, cost effectiveness were subsequently proposed. And lastly, the selective primary healthcare favored short term goals and targeted health investment, but it did not address the social cause of disease, which is actually responsible in many cases. Now, in the health services of India, we have the public and the private sector. And in the public health sector, we have the government induced healthcare systems, that is the primary health center. Then we have the sub centers under the primary health center. Then we have the hospital health centers, the community health centers. As you go higher, the rural hospitals are there, the district hospitals, and the specialist hospitals. And from there on, we switch on to the medical colleges, which actually become the training or the referral hospitals. And here is a beautiful setup of this could be a setup in a proper place, even of a primary health center, which actually has 6 beds to its credit. Then we have the health insurance schemes, which also look after this, and that is the ESI and the central government health services, which is mostly in the center areas, for example, Delhi, and the other systems, that is the railway and the defense. They have their own systems of practice and of training. Another beautiful picture of Mohanlal Gautam Rajkiya Mahila Chikitsalaya, probably it is at Aligarh, and a very beautiful building. So these are the types where you have the OPDs. OPDs are of course the mainstay. There is a small lab. There will be doctors of 2 or 3 medical officers sitting, and they would be able to look into the organ. But on the other hand, this is the picture of a polyclinic, which is actually the picture and the budding evolution of medical service today. Polyclinics, wherein a lot of doctors are actually sitting and giving separate type of health care to the patients, but on a chargeable basis. And in the private sector, you have the private hospitals, the polyclinics, the nursing homes, and the dispensaries, the general practice, and the clinics. Then you have the indigenous system of medicine, who are also now being integrated gently into the primary health center system. Plus, many polyclinics have this specialists of this, that is Ayurveda, Siddha, Unani, Tibbi, homeopathy. Then you have, of course, the unregistered practitioners, and you have voluntary health agencies, and you have the national health programs. Of this, I must mention one more, that in the village you have what is known as the traditional practitioners. They don't practice, they only practice what they have learned from their forefathers or from other people with whom they. So this could consist of jhad phook, puja part. So those practices are also there, and it must be noted that these are practices still prevalent in our settings. Now, this is the structure of the healthcare in India. We have the district hospital, we have the community health centers, the primary health centers, From the primary health center, which looks after a population of 30,000, you will have at least four sub-centers because say 5 into 4 is 20. So maybe 20 to 30, so you could have a 5 sub-center, and each would have their villages of 5 villages, each having a population of 1,000 each. Now you have a happy mother and looking very happy. Probably she has received good care, and she is happy with the services which have been provided by the primary health center. Education. Now, what is actually provided through the primary health center or through primary health care? This is education of the people about prevailing health problems and methods. We were talking about acceptable healthcare messages. This is what we are talking. Promotion of food supply and proper nutrition, adequate supply of safe water and basic sanitation, maternal and child health care and family planning, immunization against major infectious diseases, prevention and control of locally endemic diseases, appropriate treatment of common diseases and injuries, provision of essential drugs. And at the village level, we used to have the village health guide, which was started in 1977. This man was actually a class 8 pass, and he was chosen from the population of 1,000 to look after that village. He could be a male or a female, and he had to be educated at least up to 8th class. And he or she would actually conduct training of the local guides, which was started under a rural health scheme, and training of local guides for 30 days. Of course, it is not preferred. But today they are being slowly replaced by what is known as ASHA. Now, ASHA, these are literally educated females up to 8th or 10th, and with the advent of the National Rural Health Mission, that is per 1,000 we have one ASHA, and she's an important link between the community and the health services. And we have one Anganwadi worker under the ICDS scheme, one Anganwadi worker for every 1,000 population. So at the 1,000 population, we have some very important federal workers. That is the Anganwadi worker, we have the ASHA, we also have unregistered traditional birth attendants who are now coming slowly under the control of the ASHA and the midwives who are visiting the field level. Here we have, and believe me, that ASHA is actually a local resident. Preferably she should be a local resident and she could be a young person, 25 to 45 years, formal education up to 8th class, communication and leadership qualities must be there. She should be able to talk, she should be able to convince, and adequate representation from the disadvantaged population. So we cannot only go in for the higher caste, Brahman से या ठाकुर से नहीं, जो दूसरे जाति से भी हैं, उनसे भी अगर पढ़े लिखे हों, तो we must be able to choose from them and put her in a position where she could be accepted at large. Because if she is accepted, she would work for everybody plus her own community from where she comes. So she would be ensured to serve such groups better and more comfortably. Now, what is the role of ASHA? ASHA is awareness and information to the community about determinants of health, counseling of women, mobilization and facilitation of community to access health care. She works with the voluntary health agencies. She accompanies the women and the children in need of health care, and she could also treat minor ailments. She's a DOTS provider. She's a depot holder for essential drugs like ORS, and IFA means iron folic acid, and DDK and the anti-malaria drugs. Then she would also keep condoms, oral pills. She could treat childhood illnesses. So in fact, she's a ready-made doctor and a ready-made health educator at the field. Most important today, she has now to promote use of household toilets under the Total Sanitation campaign. Here is an ASHA, and she would helping enough to be able to ride a bike. And Anganwadi workers and A&M are other resource persons. Actually, A&M is the auxiliary trained nurse midwife who would be working in these areas at the village level, because she would be posted at the sub-center, but she would look after all the 5,000 population. And they would organize health days, mobilize the beneficiaries, survey of eligible couples and the children below 1 year, and weekly and fortnightly meeting of ashas by the A&Ms is a regular must, because she has to report. And then the preparation of the village health plan is a must, which she can do in coordination with the A&M. Now, the Anganwadi worker, who actually she's from the ICDS scheme, and she is chosen for her effective working as to 1/1000 population. And what she does is she includes the children. She focuses her entire attention on the children as well as the antenatal women, and she does health checkups, including maintenance of growth charts, immunization, supplementary nutrition, health education, non-formal pre-primary education. In other words, she is not going to teach them ABC or 1, 2, 3, but she would be teaching them, say, poems and small things she would teach them. Then the referral services. Beneficiaries are the nursing and the pregnant women, other women 15 to 45 years of age, and the children below 6 years. Now, in the village sanitation and nutrition committees, these are very important, because these people create awareness about nutrition. Now, in this work at the village is actually collectively done by everybody participating in these activities, although there could be a village health sanitation worker also. He creates awareness, followed by the A&M, followed by the Anganwadi worker, followed by the traditional birth attendant, followed by your ASHA. They help to carry out the surveys on the nutritional status and nutritional deficiencies in the village. They must identify locally available foodstuffs and high nutrient value, as well as disseminate and promote best practices congruent with the local culture, capabilities, and physical environment through a process of community consultation and inclusion of nutrition needs in the village healthline. In other words, they would look after what to eat, how to eat, what are the quantities in which to eat, and what are the times during special times of energy concentration, that is pregnancy, under 5. So each they would be able to drop food plans for all these groups and facilitate its working in improving the nutritional status of women and children, that is particularly the under 5s. Monitoring and supervision of village health and nutrition day to day ensure that it is organized every month in the village with the active participation of the whole village. And they facilitate early detection of malnourished children in the community. They tie up referral to the nearest nutritional rehabilitation center, as well as follow up for sustained outcome. This is most important. Supervising the function of the Anganwadi center in the village, and they act as grievances redressal forum on health and nutritional issues, because they are trained in the aspects of nutrition good for the population at large and population in question. So they become masters and they are referred to for important health educational activities. At the sub-center level, which is actually for one for per 5,000 population in general, and one for every 3,000 population in the hilly region. In the hilly regions, because of the inavailability and the inaccessibility, the 5,000 population of the primary health center is lowered to a smaller population of 3,000, so that coverage would be universal. As of 2000, total sub-centers in our country are nearly 1,45,000, as 2011 figures increased to 1,48,000. Today it is 2017, so obviously the figures are much higher than what we are projecting today. And approved staff at the field level is one ANM and one MPW, that is the multipurpose worker, male multipurpose. He is normally a male multipurpose worker who helps hand in hand and controls many situations along with the ANM at the village levels. Then there is one health assistant who are senior and who actually act as supervisory people to this ANM and to the multipurpose worker. That is the one health assistant male, one health assistant female, or they are also known as the lady health visitors, LHVs. They are located at the PHC level and are entrusted with the supervision of the 6 sub-centers under a primary health center. Now there is new patient welfare committees have been established at these villages, and they are actually known as the Rogi Kalyan Samiti, the patient welfare committees, and they are simple yet effective management structure. They are registered societies, and they act as a group of trustees for the hospitals to manage the affairs of the hospital, and actually they consist of members from the local Panchayati Raj or the NGOs and the local elected representatives and officials from the government sector. And they are the Rogi Kalyan Samiti or the patient welfare. They are free to actually prescribe, generate and use the fund with it as per its best judgment for smooth functioning and maintaining the quality of the services. Therefore, the package of service at the sub-center would be immunization, antenatal, natal and postnatal, prevention of malnutrition, common childhood diseases, family welfare services, counseling, elementary drugs for minor ailments, community health needs and various national needs programs. Sub-center Upt Swasthya Kendra, and this is probably, and to summarize, primary health care includes all areas that play a role in health, such as access to health services, environment and lifestyle. Primary health care and public health measures taken together may be considered as the cornerstones of universal health systems. The ultimate goal of primary health care is the attainment of better health services for all through equitable distribution, community participation, intersectoral coordination, using appropriate technology at the grassroots level for the grassroots people. Thank you for visiting ePathshala.